Hello, everyone. I'm Richard Manch. I am a boarded transplant hepatologist working in Arizona for many years. I'm here today to talk to you about how you can safely and easily transition your patients that have primary biliary cholangitis or PBC off OCA or Ocaliva, and if indicated, onto one of the newer medications. And I'll start by saying that this is easy to do. No one should worry. It's very safe to go through the process. It's not going to be a problem. And what we'll spend the next few minutes talking about is, what you need to know, which is not really a whole lot. My background is I've been doing liver disease exclusively for at least 25 years. I've been in the transplant side of the field, and in the last 7 or so years, as one of the founders, I'm part of Arizona Liver Health. We have outpatient liver disease clinics that also do a significant amount of research all around the state of Arizona. I've had a long and very good experience with OCA and have treated many patients with PBC over the years. I'm very familiar with the field, and I'm happy to have the opportunity to talk to you about how to handle getting patients off OCA and if appropriate, onto another second-line treatment. So I think to start with, make sure that the patient does have PBC. It's a relatively easy diagnosis. Almost always all you need is alkaline phosphatase elevation and a positive mitochondrial antibody. And some of you may have picked up patients that have been treated elsewhere or by other providers, and it's wise to make sure this is the right diagnosis. Then is the ursodiol, the vast majority of the patients are going to be on ursodiol, which we commonly call urso. Is the dose correct in the first place? Are they getting the 13 to 15 milligrams per kilogram appropriate dosing of ursodiol? Is the patient appropriate for second-line therapy? Now, we're talking about patients that are already on OCA, or obeticholic acid, or Ocaliva. But sometimes, especially, and I do this a lot, when you see a patient that maybe not originally is someone that you started on treatment, dig back in and see if this was the right move. Remembering that our feeling about PBC is the goal is to normalize the alkaline phosphatase and bilirubin, not just improve it. At that point, then you can dig into what to do about your patients that are on OCA and dealing with this situation where the company had, and working with the FDA, had withdrawn the medication. Now, it will be available through November 14th. After that, it's gone. Patients can go ahead and get refills at this time. That's important to know. And I would say that if they're tolerating OCA well and it has normalized their alkaline phosphatase and bilirubin, you need to look for that. But if that's the case, and if they're currently being prescribed on label, which means that, that it's not a decompensated liver disease patient and so on, they can continue on the medication for now until you're able to accomplish the transition. It can be refilled at this time, and you can refill it up to November 14th, but after that, it's not available. You can often get 3 months and have a nice cushion there before you absolutely have to get the patient onto a new therapy. I would suggest that look at your OCA patients, start the process now to get them transitioned to another second-line therapy, because as we all know, it can take some time to work through the insurance process. There are 2 alternative second-line therapies that are FDA approved, and I'll just, without going into much detail, just mention them. One is called elafibranor, or a brand name Curvo, and the other is seladelpar, a brand name Livdelzi. I think it's crucial for both your patients and all of you to recognize that these have different, they're similar to each other, but they are very different than OCA, different mode of action, different side effect profiles, different potential toxicities, although these are very safe medications when compared to the profile for OCA, which the patients have been on. They are called PPARs. Elafibranor is a dual PPAR agonist, and seladelpar is a selected PPAR agonist. Without getting into this science with more detail, I think I'll leave it at that. I think you'll have other opportunities to know more about it. But there's lots of information available on these medications. They've been out for over a year. We have already transitioned many patients easily and without difficulty from OCA since the news of this has been available. So, be familiar with the prescribing information of these two medications, elafibranor and seladelpar. And then thinking about OCA, the benefit will wane once it's discontinued. And I think that's a lot of people's concern. If I stop the medication, is something going to happen? And I would say you really need not worry. This does not, the effect would not be in any way abrupt. There's no withdrawal situation or no rebound. Patient is suddenly overnight going to get worse. This is not going to happen. You don't need to taper off the OCA. The half-life of the drug is about 4 days, which means it takes a couple of weeks to totally wash out of your system. There can be a period of time when the patient is not on their second-line medication. And there we should remember that this is a treatment of PBC is a lifelong process. Treatment does not cure the disease, but clearly prevents it from progressing in most cases with the promise of reversing liver damage in many patients. If the OCA is discontinued, is it likely that patients are going to notice anything? Probably not. There may be even a beneficial effect, since some patients on OCA are having worsening of their pruritus or itching, and this may improve significantly. But as far as other changes, they're not going to suddenly decompensate. They're not going to have increasing fatigue or any other problems. We don't anticipate any issues with that. It is suggested that if there is a gap, and there probably will be to some extent, while they're off OCA, they're still taking their ursodiol course. And in some cases, these meds are all approved for monotherapy if patients still tolerate urso. There is a gap in the treatment that should not be a problem. We should not be concerned. And again, I will remind you that you can get the patient refills now and up through November 14th. You should check their lab work periodically. The standard for managing PBC patients that are stable on therapy is to probably see them and check their labs every 6 months. In this case, maybe within 60 days, if the patient is still not on their new second-line therapy, you may want to check at least the baseline chemistries, alkaline phosphatase and bilirubin in particular. But it's not likely that you're going to see any dramatic sudden change. Again, this is a lifelong disease that we treat with long-term suppression. And we do get significant improvement, and remind people that the reason we use second-line therapies is we have very good data to show that if you can normalize or get the alkaline phosphatase and bilirubin as close to normal as possible, the patient's clinical outcome is likely to be significantly better. I think the only thing I'll also mention is that there are still support programs available for the patients. That a lot of the patients are very wed to the interconnect services that Intercept has provided, and that is still available. There is a phone number. I actually have it here, but you can get it from other sources, 844-622-4278. You can also, so that's an access, that's an opportunity for patients to access that number. And then also, you can contact the Intercept people directly with their medical information access line, which is 844-782-4278. I don't have those memorized. I'm reading them off a piece of paper. So, there isn't a lot to what I just told you, because there isn't really a lot to this process. You take the patient off the one drug, you start them on one of the new PPARs, which you should be able to get approved. I think the companies are all cooperating. The payers are pretty much alerted to what's going on. It should be a fairly smooth process. If there's a period of time where the patient's off their second-line medication, in the short term, it's not going to make any difference, but long term, we definitely want to get them back on second-line therapy if that's appropriate for them. And with that, I'll conclude my discussion, and thank you all for listening.